Hello everyone and welcome to my case study, patient MH. MH is a female who had 3 clinical conditions. Initially, she had recurrent diverticulitis. She was admitted to the hospital for colorectal surgery for recurrent diverticulitis and colon strictures. She had an ileostomy placed during her hospitalization, and post-operatively she had an ileus. So we had to initiate TPN, and we will discuss her nutritional implications throughout this slideshow. Thank you. So today we will be covering her 3 clinical conditions. We will begin with a brief description of each classic disease, such as the diverticulitis, ileostomy placement, and postoperative ileus. We will then discuss medical and nutritional history of the client herself, patient MH. We'll move on to GI symptoms that she experienced preoperatively, postoperatively, and what she should experience after discharge from the hospital with the ileostomy placement, with emphasis on that. We will discuss her nutritional needs while she was in the hospital and for her length of stay. We will move on to nutrition diagnosis, intervention, monitoring, and evaluation, and we will discuss what was done for her follow-up. MH is a 72-year-old female, 5'5", 161 pounds with a BMI of 27.3. Her ideal body weight was 128 pounds, putting her at a percent ideal body weight of 126%. She was admitted to the hospital for colorectal surgery for recurrent diverticulitis and colon stricture. After she had an ileostomy placement, she had a postoperative complication of an ileus, and that will all be discussed in this presentation. So we will begin by discussing MH's first clinical condition of diverticulitis and the reason that she was admitted to the hospital. We'll begin by the prevalence of diverticulitis. We'll discuss the risk factors, followed by symptoms and clinical manifestations, followed by the pathophysiology, diagnostic criteria, and prevention and treatment, and then we'll end with medical nutrition therapy. So the prevalence of diverticulitis it's the 3rd most common GI disorder and the 16th most common GI cause of death in the United States. Risk factors and etiology of diverticulitis include patients who have a BMI greater than 30 or an increased waist to hip ratio and inflammation due to high amounts of adipose tissue and increased secretion of cytokines. As we all know, an increased secretion of cytokines causes a cascade effect for inflammation, especially along the GI tract. Elderly patients are at an increased risk for inflammation in the GI tract just due to their age and the aging process. It has a risk factor for inflammation. Smokers put themselves at an increased risk for diverticulitis due to the inhalation of smoke, which causes an inflammatory effect upon the GI tract. Alcoholics also, through the consumption of excess alcohol, cause an inflammation of the GI tract. In addition, it causes an immunosuppressive effect upon the body, which increases the risk for diverticulitis. Patients who take NSAIDs regularly also have an impairment of the mucosal lining, allowing translocation of bacteria and promotion of inflammation, causing diverticulitis. Patients who have a lifelong low-fiber diet are commonly seen in diverticulitis. It's not a proven risk factor for diverticulitis development. However, you are rarely going to see a vegetarian who is admitted for diverticulitis. Decreased physical activity is also a risk factor for diverticulitis because physical activity decreases inflammation by 25%. So now we'll move on to symptoms and clinical manifestations of diverticulitis. Typically, physicians are looking for patients with left lower quadrant pain, leukocytosis, and fever as far as the classic symptoms of diverticulitis. Patients can present with persistent or intermittent pain. They can be presenting with or without nausea and vomiting. There is potentially to have increased or decreased bowel function. There's potential dysuria if the bowel is so inflamed and it affects the bladder. So now we'll move on to the pathophysiology of diverticulitis. Diverticulitis arises from the recurrent formation of diverticula. That results in inflammation of the gastrointestinal tract, a formation of abscess, acute perforation, acute bleeding, obstruction, and/or sepsis. The exact pathophysiology of the formation of a diverticula is unclear. However, the risk factors contribute to the formation of a diverticula. So once the diverticula has become formed, fecal material often become entrapped in the diverticula and cause an abrasion in the mucosa, causing a low-grade inflammatory response. With the abrasion of the mucosa, the lamina propria becomes exposed to fecal material and inflammation begins to spread to the mesenteric and pericolonic fat. Then it forms an abscess. The abscess can then form pus and cause sepsis. Another possible cause of diverticulitis is microperfusion at the fundus of the diverticulum, leading to inflammation. With this type of perfusion, the diverticula, the peritoneal cavity, becomes inflamed and has an inflammatory response. The patient will have increased abdominal pain, leukocytosis, and fever at this point. So diagnostic criteria for diverticulitis includes a CT scan, and in the following slides I have pictures of diverticulitis with a CT scan and ultrasonography scan. However, for right now, the CT scan will show a pericolonic fat stranding, bowel wall thickening, and the presence of a diverticula. The ultrasonography scan presents on the ultrasound as a thickened loop of bowel with a target-like appearance. So it literally looks like a target. And like I said, physicians are always looking for the classic signs of left lower quadrant pain, fever, and leukocytosis. So how are we going to prevent and treat diverticulitis as a medical team? Prevention is still being researched. Patients should be advised to avoid smoking, excess alcohol consumption, and excessive use of NSAIDs, and increase physical activity. Patients should be treated with diverticulitis with bowel rest, IV antibiotics and fluids, probiotics for gut flora maintenance, and if the patient has an abscess or perforation, surgical procedures such as the laparoscopic washout should be conducted in order to prevent stoma formation. However, if the gut has become necrotic, at that point open surgery will be performed to create a stoma. Currently, laparoscopic surgeries can also create a stoma, but if the patient has an abscess that has become infected, it is likely that they will conduct an open procedure. The open procedure can lead to an increased risk for complications postoperatively. So what can dietitians do for patients with diverticulitis? They can encourage increased physical activity and cessation in smoking and alcohol consumption. Previously, dietitians were advised to instruct these patients to avoid nuts, seeds, popcorn, corn, and among other things that could be stuck in the diverticula. However, a recent study from the Health Professionals Follow study suggests that there is no relationship with the development of a diverticulum and the development of diverticulitis through the consumption of corn, nuts, popcorn, seeds, etc. So we need to suggest that these people consume a GI soft diet, low spicy foods or anything that could upset the GI tract, and encourage them to avoid foods that are going to upset their diverticula. This can be individualized, and patients should eliminate foods that are evidently they're evidently irritating to the gastrointestinal tract. We will now move on to ileostomy placement. So like I said in the previous slide, this is a CT scan of diverticulitis, and as you can see, it presents as a pericolonic fat stranding with bowel wall thickening and the presence of a diverticula. You can see the arrow is pointed towards the diverticulitis. It's very hard to see, but you can kind of see the bowel has been somewhat cut in half, or an appearance of cutting in half. So you can see the inflammation in the bowel at that point. It takes a specialized doctor to read these scans and interpret the diverticulitis formation. Once again, as I said in the previous slide concerning diverticulitis, about the ultrasound scan of diverticulitis, this is a picture of an abscess from recurrent diverticulitis. It presents as thickened loop of bowel with a target-like appearance. It's hard to make out the target-like appearance in this picture. However, special training needs to be administered to the reader of the ultrasound in order to interpret the correct results. Okay, our second clinical condition involves the placement of an ileostomy. We will discuss the prevalence, risk factor, and etiology. We'll move on to symptoms and clinical manifestations, followed by pathophysiology, the diagnostic criteria to have an ileostomy placed, the prevention and treatment of an ileostomy, along with the medical nutrition therapy of ileostomy. So, the prevalence of having an ileostomy placed in the United States involves the fact that 100,000 patients in the United States have had an operation that results in the placement of an ileostomy or colostomy per year. So 70% of these patients will experience postoperative complications. So risk factors and etiology to have an ileostomy placed. This has to do with an underlying condition involving the gastrointestinal tract, or damaging of the gastrointestinal tract, or inflammation of the gastrointestinal tract. So such clinical conditions involve ulcerative colitis, which affects the entire large intestine and colon, but it's only limited to the mucosa. We also have the clinical condition of Crohn's disease, which is not continuous along the gastrointestinal tract, but it affects all the layers of the gastrointestinal tract. We also have colon cancer, and it causes death of the colon, where the colon will no longer work and they need to defecate through the ileostomy. Also, as we've already discussed, diverticular disease can develop or progress into the placement of an ileostomy if the patient experiences severe symptoms such as inflammation, abscess formation, acute perforation, acute bleeding, obstruction, and sepsis. And lastly, which is not a clinical condition, but intestinal trauma can lead to an ileostomy placement, such as maybe a car wreck or a gunshot wound that involves the gastrointestinal tract. Next, we'll discuss the symptoms and clinical manifestations of an ileostomy. I took this as after the patient has an ileostomy placed, what can we expect to see from them? This occurs in 3 phases of recovery. So the first phase is going to take place approximately 1 to 3 months postoperatively. At this point, the patient is going to experience a massive amount of diarrhea, and however, the output should not exceed 2 liters. With this high amount of output, the patient is at a really high increased risk for developing dehydration. At this point, it's imperative to monitor laboratory values to make sure that electrolytes can be replaced and fluid can be added to the patient's medical regimen. The second phase occurs 4 to 12 months postoperatively, and at this phase, the patient should experience weight gain, a decrease in output of diarrhea, an increase in absorption of vitamins and minerals, and abdominal adaptation to the stoma. It begins here. The third phase is going to occur 18 to 24 months postoperatively. At this phase, the patient will experience the maximum amount of adaptation to the stoma placed. The patient may still experience high amount of diarrhea, high amount of fluid output, and still experience absorption issues. So please monitor for that at this point. However, and thus it is imperative to monitor for hydration and making sure that these patients are retaining enough fluids to avoid dehydration. So how are the surgeons going to place an ileostomy? They place it through either laparoscopy or an open procedure where they will take the ileum of the small intestine and bring it to the abdominal wall to form a stoma, which is a small opening in the abdominal wall, and the patient uses that for defecation. So diagnostic criteria for having a ileostomy placed includes typically that the gut is no longer functioning or it has died, and the surgeon or physician will determine if the colon, rectum, or anus must be removed. If it's no longer functioning, then the ileostomy will be created. So, how do we prevent and treat ileostomies? Prevention of an ileostomy placement involves treating the underlying condition that involves the colon itself. So, ulcerative colitis and Crohn's disease cannot be prevented. However, they can be treated and the patient can be placed in remission by administering corticosteroids, anti-inflammatories, immunosuppressive agents, antibiotics, and monoclonal tumor necrosis factor antagonists. Treat these conditions. Also, omega-3 fatty acids are also known to reduce activity of Crohn's disease. If a patient has colon cancer, it can be prevented by increasing physical activity, consuming a healthful diet, and avoiding carcinogens such as charcoal or grilled foods. So diverticular disease can be prevented, as we've already discussed, but by consuming a healthful diet, decreasing alcohol consumption, smoking cessation, and increasing physical activity. So the treatment of an ileostomy, once it's been placed, the patient may not be able to prevent the demise of their small intestine. Thus, the ileostomy is going to be placed. So this is a very emotional surgery for people, so the medical staff really needs to implement emotional support and help the patient learn the care of the stoma. We need to encourage these patients to avoid lifting heavy objects, and they need to understand the medical nutrition therapy of new ileostomies. Actually, the dietitian has a very pivotal role in patient education for the treatment of ileostomy placements. So after receiving the stoma, the patients will likely experience stress, depression, anxiety, as the stoma alters their self-perception. So like I said, the medical staff needs to offer support, maybe direct the patient toward a support group for emotional reasons during this difficult time. They need to learn how to care for the stoma, such as cutting the pouch to fit the stoma, aligning the pouch properly with the stoma, applying the pouch to avoid creases and leakages, and cleaning the stoma. And they also need to learn the complications that involve stomas, so they can talk to the doctor if they're experiencing issues. So we'll move on to medical nutrition therapy of stoma placement. If the terminal ileum is removed, bile acids and intrinsic factor-bound vitamin B12 should be replaced in the diet. So, as dietitians, we need to view the recovery period as phases. So, like I was discussing, phases in symptoms and clinical manifestations, there are also phases for medical nutrition therapy with this operation. So, during the first phase, TPN may need to be initiated if output is extremely high or if the physician wants complete bowel rest, if the GI tract was extremely compromised. So you want to start TPN at a low rate and advance slowly to avoid refeeding syndrome if your patient hasn't eaten very much preoperatively. Also, like I said, if diarrhea exceeds 2 liters, then TPN may be considered as a lifelong treatment. During the second postoperative phase, TPN can be reduced and enteral nutrition may be initiated at a slow and continuous rate. This rate should be adjusted according to stoma output. If weight loss is greater than 1 kilogram per week, or if the diarrhea exceeds 600 grams per day, TPN may need to be reinitiated, and if it was previously turned off. So during the third phase, TPN can be discontinued, enteral nutrition should be discontinued as well, and oral intake can start to become the patient's method of receiving nutrients. So oral feeding should be comprised of approximately 6 small meals a day, high in carbohydrate and low in fat. When oral feedings begin, patients should be instructed to consume a low-fiber diet for approximately 6 to 8 weeks postoperatively to avoid additional bowel swelling. When they are allowed to resume their regular diet, they should be instructed to consume one food at a time in order to observe for possible gastrointestinal upset. Like I said, individualize their diet because some foods that affect some patients may not affect others, and it can be very individualized. So also, as far as supplementation or vitamins, patients should consume or have adequate blood levels of zinc, potassium, liquid magnesium, oral calcium, iron, vitamin C, selenium, and vitamin B complex. In addition, if the patient is receiving antibiotics, they may need to receive additional vitamin K supplementation. Patients may be initially lactose intolerant following this surgery and require oxalate-restricted diets. These patients should also eliminate caffeine and alcohol from their diet unless otherwise instructed by the physician. If the patient develops osmotic diarrhea postoperatively, they should be instructed to reduce simple carbohydrates and increase complex carbohydrates. Okay, and now we will move on to the postoperative ileus. Okay, so for our third and final clinical condition, we will discuss an ileus postoperatively. The prevalence of developing an ileus includes about 22 million inpatient surgical procedures are performed per year. So of those procedures, 2.7 million lead to a postoperative ileus that lasts multiple days. So risk factors for developing an ileus include abdominal incisions, manipulation of the bowels, and extensive dissection that is often required to remove abdominal lesions. Other causes of an ileus include inflammation of the intestines, hormonal effects, and opioid use. So symptoms and clinical manifestations of an ileus include nausea, vomiting, abdominal distension, diet intolerance, inability to pass flatus and form stool, anorexia, and pain. Decreased movement of the GI tract will cause fluid retention and gas buildup or abdominal discomfort. So the pathophysiology of an ileus includes, it's a multifaceted condition and it's linked to events that occur intraoperatively and postoperatively. So intraoperatively, the type of procedure that is performed on the patient, the amount of venous fluids that are administered during the surgery, the use of anesthetic agents, the length of an incision that's made during an open procedure, and the extent to which the intestines were manipulated during the surgery. And if the procedure was an open or closed procedure, also impacts the formation of an ileus. So an open procedure is more associated with the development of an ileus than a closed procedure because it causes a greater amount of tissue destruction, an increase in pain, and decrease in mobility of the patient postoperatively. So a closed procedure is associated with a decrease in intestinal manipulation, a decrease in trauma to the skin, and it is associated with a faster recovery. So intestinal manipulation is associated with the development of an ileus because as the manipulation is occurring, the body creates an inflammatory and endocrine response, ultimately increasing the chance of developing an ileus. So postoperatively, an ileus can develop if the patient is in PO for an extended period of time, if the patient is using opioids for pain control, if an NG tube is being placed for decompression, if the patient is less mobile than before the procedure, and if there is a delay in the use of enteral nutrition that causes the loss of the GI motility or GI mucosal integrity. So how are we going to diagnose an ileus? It's basically identified through the symptoms, like I said, and nurses are watching the patients for these symptoms postoperatively, so such as abdominal pain, abdominal distension, if they're nauseous, if they're vomiting, are they having diet intolerance, are they failing to pass stool, flatus. So right now, or previously, nurses would use auscultation for bowel sounds as a reliable indicator to diagnose postoperative ileuses. However, these days and through current research, that's not an identification factor that's valid anymore. So we are more focused on if the patient is passing flatus, are they having bowel movements, are they experiencing nausea, vomiting, and abdominal distension, and not tolerating their diet. So no longer are we relying on bowel sounds for the presence of an ileus. An ileus is confirmed through a CT scan, X-ray, barium enema, or upper GI and small bowel series. So the prevention and treatment of an ileus. The formation of an ileus can be prevented through stressing the importance of early mobilization to the patients postoperatively. So intraoperatively, the physician needs to provide a judicious amount of IV fluids and consider using epidural anesthesia opposed to general anesthesia. So by using a thoracic epidural as opposed to general anesthesia, the patient is allowed earlier ambulation and earlier oral intake. The epidural can also be used to administer local anesthetics for pain management, which avoids the use of systemic opioid use and slowing the GI tract. The physician can also limit routine use of NG tubes and quickly removing them. Urinary catheters should also be used sparingly. Patients should be encouraged to move soon after surgery and frequently during their hospital stay. The nurse caring for the patient at risk for developing an ileus or who has an ileus must document how much the patient is ambulating, pain management methods, if the patient is tolerating the diet, and the amount of IV fluids that are being administered. So once an ileus has been identified, a prokinetic agent, such as Reglan, can be administered to stimulate the GI motility. The patient can also be advised to chew sugar-free gum to stimulate cephalic phase of digestion and increase gastric motility. It is also suggested that patients can rock in a rocking chair to increase GI motility. So if oral nutrition is delayed postoperatively, enteral nutrition should be initiated. If bowel rest is needed or an obstruction has occurred, total TPN should be initiated for nutrition support. So what are we going to do as dietitians? Our goal is to prevent an ileus from forming by early enteral feedings or oral feedings to increase GI motility. But once the ileus has been identified, we need to encourage the patients to chew gum and stay hydrated. So if the gut is no longer functioning, TPN is suggested, but only if parenteral nutrition is going to be administered for greater than 5 days. And that's typically if the it varies by physician that if they think that the ileus can be resolved or not. Some physicians have been starting TPNs very rapidly and others wait a few days. So the use of enteral nutrition. So now we're going to discuss MH's patient history. In 2005, she had a coronary artery bypass surgery. In 2010, she had breast cancer with a lumpectomy. She has a history of heart attack, hyperlipidemia, hypertension, type 2 diabetes. And on January 12th of 2016, she had a colonoscopy which confirmed a colon stricture, which led to her current hospital admission. So during an acute diverticular episode, MH was prescribed antibiotics and was recuperating at home when she experienced increased amounts of abdominal pain. Her GI physician then decided to see MH and discovered the colon stricture through the colonoscopy and a gastrograph and enema. 3 weeks later, MH was admitted to the hospital for a laparoscopic diverting loop ileostomy placement. And during this procedure, an intra-abdominal abscess was discovered, which changed the procedure from a laparoscopic procedure to an open exploratory laparotomy. So post-operatively, MH's abdomen became distended with increasing nausea, which confirmed an ileus through a CT scan and led to bowel arrest and the use of TPN. Okay, for this slide, we're going to discuss MH's laboratory values. First, we'll address her sodium levels. They were low and trending down because the patient was dehydrated and had poor oral intake of fluids. Another cause of her low sodium levels include the administration of hydrochlorothiazide and a diuretic therapy for improvement of her blood pressure control. Her chloride levels were low and trending down because of cation and osmotic changes in the body. MH's glucose and fasting blood glucose were high because of her diagnosis of diabetes and the need for insulin. The increase in BUN and creatinine ratio was likely due to the decrease in blood flow to the kidneys related to her congestive heart failure, which was found on a CT scan of the chest on February 24, 2016. While observing the decrease in MH's ionized calcium levels from 8.5 to 8.3, one must consider other markers such as vitamin D5 and vitamin A for indications of calcification of soft tissue. MH's total protein levels were decreasing due to an acute inflammatory response, and it was also reflecting her stage 3 chronic renal disease. The low albumin levels were also reflecting her short-term diet of clear liquids and chronic renal disease. Magnesium levels were decreasing related to the hypomagnesemia that was replaced to avoid convulsions, tetany, and hyperirritability. The white blood cell count was high due to infection of the abscess, but was decreasing from 21.3 to 21.0, and the patient was afebrile during the time that these labs were drawn. The red blood cell count, hemoglobin, and hematocrit were chronically low in this case, related to a history of chronic anemia. The MCV was increased, likely related to a folate or vitamin B12 deficiency. The platelet levels were high due to high amounts of coagulation in the blood. The patient was put on DVT prophylaxis. So those are basically the nutritionally significant laboratory values that I found in this patient. For this slide, we will discuss MH's diagnostic procedures that were taken during her hospital stay. So, with reference to this table, she had a colonoscopy that indicated a colon blockage back in January of this year. In addition, this patient has had recurrent diverticulitis leading to gastrointestinal concern and reason for her current hospitalization. Prior to laparoscopic converted to open low anterior resection, rigid proctoscopy, splenic flexure mobilization, omental pedal flap, drainage of intra-abdominal abscess with diverting loop ileostomy performed on February 16, 2016. Another colostomy colonoscopy was performed on the same day, which indicated her recurrent diverticulitis. So the previously mentioned procedure that occurred after this colonoscopy indicated sigmoid colon stricture due to her history of complicated diverticulitis and adenomatous colon polyps, pelvic abscess, dense pelvic adhesions. On February 22nd of 2016, a CT scan of the chest and abdomen was performed, which indicated that the NG tube was placed in the stomach was distended, and there were moderate amounts of perihepatic ascites. There was mild diffuse ascites. The small bowel loops were markedly dilated. The skin staples were in the anterior abdomen. There was minimal free intraperitoneal air, which is presumably post-operative. The overall impression of the CT scan was indicating dilated small bowel in the stomach consistent with small bowel obstruction, likely related to heterogeneous mass in the right abdomen, which represented a hematoma. On February 23rd of 2016, another CT scan of the abdomen was completed, and this confirmed the post-operative ileus. Finally, on February 24th of this year, a CT scan of the chest was completed, which confirmed congestive heart failure. Those are all of the diagnostic procedures that were taken of our patient MH during her hospital stay. Now we will discuss nutritionally pertinent meds, and we'll begin with Intreg. That is an opioid antagonist, which is indicated to accelerate the time the upper and lower GI tract recover following surgeries that include partial bowel resections. She was also administered insulin, glucagon, glucose, and glipizide due to her type 2 diabetes. She was administered antibiotics for various reasons. Lisinopril and hydralazine were administered for hypertension. D5W was administered to maintain glucose control prior to administering TPN. Cholecalciferol was administered as a supplement for the calcium regulation. She was also given a multivitamin to provide the body with additional nutrients. She was given pantoprazole as an anti-ulcer, anti-GERD medication. After speaking with MH, we discussed her GI symptoms before admission and after admission and her procedures. So before admission, she indicated that she had lower quadrant pain with nausea, and she was very aware of how it felt like diverticulitis. So after admission and after her procedures, she was eventually able to have bowel movements with flatus, but with the ileus, she had bowel movements without flatus. She had abdominal pain, she was nauseous, and then she had her ileus, which decreased her GI motility. So physically, when I was looking at this patient, she had no edema, she had no skin breakdown because she was a very active lady with her grandkids. The estimated needs for MH were estimated using Mifflin St. Jeor with an activity factor of 1.2, and that gave us 1,500 to 1,700 calories per day, and that's basically giving it a 200 calorie range. So we could watch her consumption very carefully with the TPN administration. The protein needs were calculated using a 1.1 to 1.2 gram per kilogram of actual body weight. So that gave us 81 to 88 grams of protein per day. And then the fluid needs were based off of the typical 1 ml per calorie consumed. That gave us 1,500 to 1,700 mLs per day. Nutritional diagnosis that was needed for patient MH, of course, first we had altered GI function as a problem because she was admitted for recurrent diverticulitis. And then we saw this through a postoperative ileus and the need for TPN. She was also having inadequate oral intake during this time because she was NPO in clear liquids for approximately 7 days due to bowel rest. As there are additional needs for patient MH as far as nutrition diagnosis is concerned, these are the two main problems, nutritional problems for monitoring and evaluating patient MH included monitoring the fluid and electrolytes to ensure that they weren't going out of range for refeeding syndrome because she was on clear liquids and NPO for 7 days, and then we were initiating TPN. I also wanted to watch her glucose levels because she was a type 2 diabetic, and we were administering glucose and then administering TPN, and I wanted to make sure that she wasn't getting too much sugar from her clear liquid supplements as well. I wanted to watch her weight maintenance because she was on the clear liquid and NPO for quite some time, so I wanted to make sure she wasn't edematous as well through no weight gain, so my goal there was no weight changes. Energy intake, I monitored through the TPN administration and calculation of the rate along with the amount of dextrose and amino acids and lipids that were administered every day. I watched ileostomy output in addition to that to make sure she wasn't going to become dehydrated and make sure that she wasn't exceeding 2 liters a day of output. I watched the passage of flatus and stool through the stoma to make sure that her GI tract was functioning and that where she was having stool output but no flatus, then we knew that the ileus was present. So with the resolution of the ileus, she began to pass flatus. So for my follow-up with MH, I recorded that the output of her stoma was 600 mLs and then the TPN was initiated. The magnesium level was proven to be low, and I called the pharmacist and made sure that it was going to be replaced by pharmacy. They were on top of it and replacing it already. The sodium was low, and that was related to dehydration, so we had to make sure that she was receiving adequate amounts of IV fluids. And I also monitored her CT scans to see the progression of the ileus and if it was resolved by the end of her stay at the hospital. That was basically my case study.